Single stage revision, thanks to Dr. Harish Bende, he has covered most of my talk. And PJI is a dreaded complication for any orthoplasty surgeon. Broadly, it can be classified into early up to first 3 months, delayed 3 to 24 months, and late more than 24 months. So this meeting, international consensus meeting held in 2013, they came up with these suggestions where the major criteria, two positive cultures of identical organisms or a sinus tract communicating with the joint, and minor criteria, elevated CRP, raised WBC, increased polymorphs in the synovial fluid. Taking it further, the ICM in 2018 retained those major criteria, but minor criteria were divided into two: pre-operative diagnosis, as you can see here, and intraoperative diagnosis. And they, scored it, and any score more than 6 is a confirmed PJI. So McPherson staging system, they took into consideration infection type, systemic host grade, and local extremity grade. So for single stage revision, this local extremity grade and systemic host components are most important. Systemic host factors, age more than 80, alcoholism, renal issues, liver issues, indwelling catheters, local parameters like multiple scars, compromised skin condition, discharging sinuses. So based on this, McPherson categorized this into systemic host and local factors. So if you are planning single stage revision, you would like to have a host type A where there is no compromise with local factor type grade 1. So that would be ideal scenario to opt for single stage revision. Type C with type 3 is not an ideal candidate for single stage revision. So we are going to take into consideration preoperative consideration, intraoperative procedures, post-op management, and review of literature. So before you embark on journey of single stage revision, you should have a medical team in place, and ID consultant definitely plays a crucial role in this, and all antibiotic protocols should be decided by ID consultant. Microbiology is also a key person in this team. So patients with no sinus tract, no soft tissue compromise, appropriate bone stock on CT and X-rays, favorable identified organism responsive to IV as well as oral suppression later is extremely important, and host should have robust immunological status. These are the prerequisites. In such patient subset only you should think about single stage revision. We can divide this into 4, like preparation, initial debridement, timeout phase, and implantation of new processes. So preparation and debridement, they say you should learn from your oncosurgery colleagues and you should debride it thoroughly. And many papers have suggested that this debridement could be without tourniquet, so you can differentiate between the necrotic tissue and the healthy tissue. You should have bleeding tissue at the end of debridement. Minimum 5 samples for microbiology should be collected, and after that only you should administer IV antibiotics, okay, that is necessary. Processes removal is done, and reaming should be done till you have bleeding cancellous bone. Once you do that, then you should give saline wash. Many studies have suggested up to 12 liters of saline wash, and with aqueous povidone iodine. This is necessary, and you should have some exposure time for local action of iodine. Then comes the timeout phase where temporary wound closure is done, and then some studies they have suggested to shift the patient to clean theatre or next adjoining theatre. Surgical teams re-scrubs and re-prepping and draping is done as if you are starting a new case. And then after that, new processes implantation is done. Antibiotics with prior antibiotic protocol can be added into the cement or topical antibiotics. Calcium sulfate beads can be considered, especially in cementless implants. And saline wash, if you are going to use calcium sulfate beads, then saline wash should be given prior and then put the calcium sulfate beads. And watertight closure is mandatory. Post-operatively tailored antibiotic plan as per ID consultant and aggressive physiotherapy is mandatory. So SSR, there are distinct advantages of it is a single stage procedure, reduce risk of multiple procedures associated with a two-stage procedure, reduce antibiotics and inpatient stay, and it is definitely economically cheaper, better for the patient. But let's go into a review of literature. This study published in 2015 by Haddad et al. And they found 0% infection in 28 chronic PJI cases at the end of 3 years with patients treated with single stage revision. So they took into consideration patients whom they selected for single stage revision. They had minimal bone loss, non-immunocompromised host, healthy soft tissues, and a known causative organism preoperatively. These are mandatory things. Another study published in 2013 in International Consensus Meeting on PJI, and they came up with these suggestions of there should not be any systemic signs of sepsis, significant soft tissue inflammation should not be there, sinus tract, absence of identified organisms. So, in addition, polymicrobial infection, gram-negative bacteria, and atypical infection, these patients should be avoided or should not be posted for single-stage revision. Study published in 2016 by Endoclinic Hamburg, and they actually ignored this microbiological factor and they said it is not an absolute contraindication. I'll just take a minute. Another study published in 2019, a review article, and they found no difference in clinical and functional outcome when compared with single stage versus two-stage revision. There are various studies where they come up with, they proved that there is superior functional outcome when you opt for single stage revision. Study by Haddad et al. Published in 2015, they concluded with 102 patients and they found fewer complications with single stage revision, 0 reinfection with single stage revision as against 6.8% with two stage revision. So, a study published in 2021, 185 consecutive revision TKR for PJI, and they reported higher patient reported outcome measures with single stage revision. Another study published in 2016 by Endoclinic, 93% infection-free survival at 10 years. Recent study published in 2024, a systemic review and meta-analysis, and they found no significant difference in reinfection and reoperation rate, but patient-specific factors are most important while opting for single-stage revision. A study by Ridden Morgan Jones, very high-volume surgeon from UK, and conclusion was single-stage revision using strict debridement protocol and multidisciplinary input is effective treatment option for infected TKA. And lastly, study a review of current concepts for single-stage revision by Pradhan et al. And they found SSR is a reliable option, right selection of patient is important, extensive debridement pathogen identification is important, appropriate reconstruction strategy and appropriate antibiotic therapy under ID consultant with adequate follow-up. And importantly, we should have a team approach when dealing with these patients. So friends, appropriate patient selection is key to success. Surgical technique and team approach is very important. Thank you very much.